Okay, welcome everyone to the OLLI Medical Series. Today we'll be talking about healthy sleep habits. Just a quick reminder, next week is OLLI's spring break and there will be no classes. Today we have Dr. Douglas Trask, who's a professor in the Department of Otolaryngology, Head and Neck Surgery at the UCI School of Medicine. Dr. Trask specializes in surgical and other alternatives to CPAP therapy for the treatment of sleep apnea. He has been at the forefront of research bringing state-of-the-art treatments to people with sleep apnea, including sedated elevation of the airway and neurostimulation therapy. He is a member of the Comprehensive Sleep Medicine Center at UCI. Today, Dr. Trask will be discussing symptoms, diagnosis, and management of sleep apnea and healthy sleep habits. So, Dr. Trask, go ahead. I'm going to stop sharing my screen. And if you want to share your screen again.
Okay.
And Dr. Trask will be taking questions as they occur, so you could raise your Zoom hand or type them into the chat.
All right, I'm just trying to advance the slide here.
Sometimes you need to click into the window first.
Let me see here. There we go. Thank you. Oh, thank you. Thank you for that introduction. Glad to be virtually here today. And just going to give you a few pointers and tips about diagnosing sleep disorders, treatment, and then ending up with a little bit of information about state-of-the-art treatment for obstructive sleep apnea. So I have no financial disclosures to discuss. And the first thing to talk about is just what is the definition of insomnia. And the important thing here is it's the perception of insufficient or disturbed sleep. So patient could have a normal night's sleep by our definition, but if they felt that it was non-restorative or otherwise problematic, that is one of the definitions of insomnia. And in general, there are lots of reasons for insomnia, including just lying there awake all night. But is this really a perceptual problem, or is it truly something going on with the anatomy, how the neurons are all connected within the brain? And of course, I don't expect to review this in great detail, but the point is that this just shows regions of the brain that are active in a person that has insomnia that should not be active at night. So this really is a structural problem. This is not simply a perceptual one. And it's also very common. This just shows reports of insomnia, male and female differences. And you can see 10 to 15% of folks have problems with insomnia almost every night. And the vast majority report at least problems a few times a month to weekly. And it's also underreported by the patient. So they're going to come in with a list of problems, and usually insomnia doesn't even hit that list. So you can see 70% of people that have insomnia never discuss it with a healthcare professional. Maybe a quarter of them will at least mention it, and actually scheduling an appointment specific for the diagnosis is relatively rare. And you can see what ends up happening is that most patients treat themselves with over-the-counter medications. It really is a problem of aging. If we look at 10 to 20-year-olds, sleep problems constitute less than 20% of individuals. And by the time that we get into our 70s, essentially half of our folks have problems with sleep. So this definitely is a problem of aging. And there are a number of things that happen as we get older. The time in bed increases, the number of awakenings increase, time to fall asleep increases, and in general, this all relates to daytime symptoms and dissatisfaction with sleep. This just shows the number of awakenings. This does not mean totally awake and getting out of bed. These can be micro arousals and things like that. But you can see once again, if you look at the trend, 20-year-olds have limited number of awakenings at night, and by the time we reach 80, that number is almost 50 per night. The quality of sleep also changes. One thing that remains relatively consistent as we age is REM sleep, or that rapid eye movement sleep. And about a quarter of our sleep is REM related sleep, and that stays the same. But if you look at delta sleep, that's the deep, very restorative sleep. You can see that really plummets with age, and by the time we reach our 80s, there's very little delta sleep recorded in any given night. Sleep efficiency, that's the time actually asleep versus time in bed, decreases with aging, as you would expect. What is the overall consequences of insomnia? It ranges from impaired social relationships, difficulties with memory and concentration, and for those that have chronic insomnia, significant daytime sleepiness and increased problems with driving accidents and other issues. Those are some of the things that I guess we would say we would expect to see with a person that has insomnia, but it really has far-ranging consequences, including susceptibility to the common cold. This is a very interesting study. This was individuals that literally were inoculated with the rhinovirus that caused one of the viruses that caused the common cold, and then stratified according to how much sleep that person got. And you can see those that got what we consider to be, quote unquote, a normal amount of sleep had about a 15% chance of having objective cold symptoms. And those that slept less than 5 hours, almost a 50-50 chance of developing the cold. So really, this is very far-ranging problem. So why are patients not sleeping? So this is the kind of the diagnostic portion of things. It can certainly be due to medical conditions. You're familiar with most of these causing problems, hyperthyroidism, any condition that results in chronic pain is usually disastrous for sleep, reflux, and even chronic tinnitus can be a source for insomnia. Also, take a look at the drugs that person is on. There are all kinds of drugs that affect sleep. Those that cause insomnia are shown on the left there. Alcohol is a big player. We'll talk about that in a minute, but everything from beta blockers to bronchodilators to corticosteroids can be a source for insomnia. So for instance, dosing corticosteroids, recommend to do it first thing in the morning to try to mimic the cortisol release that's under circadian control. So I always have patients take steroids first thing in the morning. Drugs can also cause sedation. You're probably very familiar with these and perhaps use some of these as a sleeper yourself. It can also be due to primary sleep disorders. Of course, I don't have the time to go into each one of these. But just to highlight a couple, paradoxical insomnia, that gets back to the definition of insomnia. And this is where individuals will actually sleep based on either a polysomnogram or actigraphy for 7 or 8 hours a night. But if you ask them, they say, I only sleep an hour or so at night. So their perception of their sleep is vastly different than their actual sleep. Periodic limb movement disorder is another diagnosis that can only be made with a polysomnogram. But if you have more than 15 of these events per hour, that can be a cause for disrupted sleep. Restless leg syndrome, an urgency to move legs, usually worse in the evening or nighttime. Circadian rhythm disorders. We're all familiar with jet lag syndrome, shift work disorder. Of course, working the night shift, about the worst thing you can do for your circadian rhythm. Advanced sleep phase syndrome. I'll discuss that very briefly, but that again is usually an issue with the elderly going to sleep too early. And what are some of the things that you can do to help out with that? So it all comes down to light therapy. And so standard phase is going to sleep approximately 11 o'clock, getting up approximately at 7. If you have advanced phase disorder, going to sleep anywhere from 6, 7, or 8 o'clock. You can see the answer is light therapy to try to entrain the circadian rhythm to a more, at least socially acceptable pattern. And that has to do with the direct connection between light entering the retina and direct pathways right to the brain that regulate the sleep-wake cycle. And one thing that we really don't take into account are light exposure in nursing homes or other assistive care institutions. And the amount of light that these folks getting is paltry at best. You can see median light level was 54 lux. If you're outside, you're getting thousands of lux of light there, or light exposure, and that incredibly weak amount of light exposure was only about 10 minutes, which is not sufficient to reset that circadian rhythm. So what can you recommend? We'll discuss this in a couple of ways, but no more than one 30-minute nap per day, and that should be before 3 p.m. Exercise, it's best in the afternoon. We'll get into that. Get light exposure, and then if you're trying to correct the problem, the right timing for light exposure. And the best light is sunlight. It isn't even just indoor lighting. By far the best light to get is sunlight, and that means if you're outside that you're also not wearing sunglasses, because you're going to block some of the important wavelengths with sunglasses. So when getting light exposure outside, recommend that they don't wear sunglasses. Sleep restriction, we'll talk about that in a minute.
We have a couple of questions in the chat. If you're
Sure, go ahead.
Bill, we can't hear you.
okay, GABA, etc. Does that help?
Sorry, you're still breaking up.
Yeah.
Okay, just a second.
Maybe I can.
Is that better?
So far, yes.
Okay, so they're just talking about what you were talking about, going to sleep at 9, waking up at 4, and supplements. Do the supplements help? Like chamomile, lavender, magnesium, calcium?
Some of the supplements can be of benefit, but they're quite limited. I'm going to talk specifically a little bit later about melatonin, which is probably the most common agent that is used for circadian rhythm issues. And it actually works quite well for a circadian rhythm issue, like advanced phase disorder and others of that nature. Does not work so well for somebody if they're just suffering from, shall we say, regular insomnia. The supplements that have been mentioned have some benefits. The number one treatment for most of this ends up being cognitive behavioral therapy that we'll talk about in a minute. Is that the only question, or?
That's the only one for now, since you'll talk
Okay.
about melatonin later.
Yeah. Okay. So this was just a summary. I think I've kind of gone over that, so we'll keep on moving here. So now we're getting to sleep hygiene, which is a big issue with many patients. And kind of the rule of thumb here is that there are probably, shall we say, about a dozen sleep hygiene no-nos that most of us, including many of our patients, don't follow. But if you try to present a list of 8 or 10 things that a person needs to change in order to sleep better, guess what? They're probably not going to do any of them. So we really say pick 1 or 2 rules that are violated and try to work on those. And if you have success with those, then move on to the next ones down the list. So what are some of the sleep hygiene rules? Reduce time in bed. That's called sleep restriction. And it may seem a little paradoxical, but what you're trying to do is to build up the sleep drive. And the way to do that is to restrict sleep. Avoid trying to sleep. That sounds, it's a very common issue, I guess I should say. Just lying in bed and trying to go to sleep. We recommend 20 minutes. Being in bed. If you can't sleep, get up, get out of the bedroom, go do something else, wait till you're tired, and then come back. Avoid clock watching. We literally have folks turn, if they have a bedside clock, to turn it away from themselves so that they can't see the clock. Avoid late night exercise. We'll explain that in a little bit. Avoid daytime naps. And if you have to take a nap, like I said, 1 nap, 30 minutes before 3. Tobacco, alcohol, and caffeine are also very disruptive for sleep, so obviously avoid those. So reduce time in bed. Staying in bed longer than the body needs causes insomnia. Cut down time in bed by 1 to 2 hours. Never less than 5 hours, but cut it down by a couple of hours sometimes is necessary. When you do that, there's less awakenings and more deep sleep. Use temperature to your advantage. So one thing we know about insomniacs is that their ups and downs of temperature is relatively muted, and they have a more flat temperature cycle. So you want a cold, shall we say, body temperature in order to sleep well. And how can you improve your chances of having a low core temperature? You can do exercise, and it needs to be pretty intense exercise for at least 20 minutes. What you're trying to do is increase core body temperature. That is then followed by a rebound in core body temperature that actually lowers the temperature, that happens about 6 hours later. So that's why we say no exercise right before trying to go to sleep, but the best time to get that exercise is about 6 hours before bedtime. The alternative is you can take a hot bath. Obviously, that's not getting exercise, and so we'd rather see you get exercise. But if you're to do the hot bath thing, same idea, you're increasing core temperature, but the rebound cooling that takes place after a hot bath happens after about 2 hours. So we want that hot bath a couple hours before going to sleep. This just shows that it's a continuum, and it always doesn't have to be intense physical exercise that can benefit sleep. You can see folks that had essentially no activities, percentage of insomnia was about 25%. And as you increased activity from just social activities to walking to more vigorous activities, things improved in terms of sleep, but even those that had just social activities can make a difference. And so, especially again in the elderly, we're not talking about going out and trying to run a marathon or something like that, but just trying to improve interactions and walking as hopefully we get to a better post-COVID environment. Mentioned naps a couple of times, but those that nap, 80% report worse sleep. Relaxation therapy, very important. We're talking about, we're trying as much as possible to avoid any pharmacologic intervention. And so relaxation is critical to this. We've talked about sleep restriction. Like I said, no less than 4 or 5 hours. Don't sleep outside of these hours. And then they need to keep a sleep diary of how they're sleeping. And once sleep efficiency gets to be, that's the amount of time of sleep per time in bed. Once that gets to be better than 80 or 85%, you can increase the amount of sleep that they can get by 15 minutes, and then you can keep doing that till they get to a normal night of sleep. Stimulus control therapy is based on the premise that if you sit in bed worrying about sleep, it's not going to help. So as we said, if it's been more than 20 minutes, get out of bed, do something else. Do not engage in something that employs a screen, but some other restful activity. Use bed only for sleeping. Do not read, watch TV, or eat in bed. We all know about that. And the number one recommendation, this has been reiterated time and time again, is something called cognitive behavioral therapy for insomnia. It is recommended as the initial treatment for chronic insomnia. So before any drugs are tried, before anything else, this can be done usually through a licensed professional, but there are some alternatives. Let's see here. Sorry, I'm just trying to forward. And one of which is actually a phone app that I actually think is pretty good. It's called Sleepio, and it's available on iPhones. And it is your own personal electronic cognitive behavioral therapist. And it is kind of works off of an algorithm. And so it's going to ask you a series of questions about your sleep, and it's going to recommend a particular action. You try to employ that action, and then you basically report back to the system whether it worked or not, and then it will kind of take you down the next step to try something else. It also has the ability to import information about your sleep and use that as well. So there are a number of programs like Sleepio that are out there right now that can work for you. What can your patients do? Get rid of blue light. Almost all LEDs produce a tremendous amount of blue light, and that is the stimulatory light that keeps you awake. So it doesn't matter whether it's an iPhone or an iPad or a computer or whatever it is, generates a lot of blue light. A couple solutions to that: one, just don't use an electronic device. Number two, there are blue blocking lenses. They used to be kind of these pretty bright orange glasses to prevent blue light passing. They're now clear lenses that you can wear that can answer that question. There are also even settings on our smartphone. So if you go to, I believe it's an iPhone display and brightness, and there is a toggle switch in there called night shift. And basically you set the hours where you want your phone not to emit blue light. So you can have night shift kick on at say 8 o'clock at night, for instance, and your display will shift. It turns a little orange, but it's still very readable and something that you might want to try. Menopausal insomnia. Why is that? Again, we're getting back to that temperature cycle, and that is really the problem. So anything that can help with cooling at night can help these women pretty significantly, actually. Caffeine insomnia, we've talked about that a couple of times. Remember, caffeine is in a lot of things, certainly coffee, but can be in iced tea, chocolate, energy drinks, all kinds of things. One of the important things to realize is that people metabolize caffeine differently. So there are some people that can metabolize it quite quickly, and there's others that it can remain in their system for quite a period of time. So the rule of thumb is no caffeine after lunch. And so typical half-life could be something on the order of 6 hours. So even if you had a cup of coffee at noon, at 6 p.m., 50% of that would still be in your system, and at midnight, a quarter of it would still be in your system. So you got to think about the fairly long half-life of caffeine. Altered schedules, very bad for sleep. Try to maintain a regular schedule, and that includes both weekdays and weekends. So keeping a regular sleep-wake cycle can help quite a bit with insomnia. We talked a number of times about limiting naps and substituting exercise. Bed confusion insomnia, in other words, keep it simple. Not a lot of different activities in the bed. Alcohol insomnia. Alcohol can certainly help you to fall asleep, but once the metabolites are made of the ethanol and in your system, they can be very disruptive to sleep. So the second half of the night after excessive alcohol ingestion is when sleep gets very, very disrupted. Prescription insomnia, we talked about that. Make sure you review with the patient not only the medications they're on, but best time to take them. One of the examples I gave was corticosteroids and taking those in the morning. Others, such as the tricyclic antidepressants, best before bedtime to take advantage of. Anxiety, insomnia, lying awake in bed, thinking about everything that happened during the day. That's where the cognitive behavioral therapy really can kick in. Don't stay in bed if you cannot sleep. We talked about that 20-minute rule. Is this a sign of something else going on? Certainly a quick review for sleep apnea is important, as well as depression. over-the-counter medications, it's important to review those as well, to see if the patient is on any medications, and histamines first generation especially, or other problematic over-the-counter medications. As I mentioned, I was going to briefly talk about melatonin. Melatonin is very good at helping to treat circadian rhythm disorders, such as if you fly 3 time zones and you want to readjust to the new time zone, it's very good for things like that. It can be helpful for people that have work related disorders. But the question is, how useful is it for other problems? In as much as we think that it's a benign medication, it can have other repercussions. And so the normal melatonin dose should be somewhere between 0.1 and 10 milligrams. I typically use it in the 1 to 3 milligram range. And if I'm really want to use it for all it's worth, shall we say, I will actually prescribe it. And why would I prescribe it? Well, as I'm sure you're aware, supplements are not regulated by the FDA, and there have been a number of studies that have looked at the actual concentration of melatonin in a capsule or pill as it relates to the labeling on the bottle. And the studies have shown that it can contain anywhere from only 20% of what is labeled to over 400% higher amounts of melatonin than actually labeled. So I think it's important if you're going to use it to actually use it as prescription grade. And other than circadian rhythm disorders, how much is this going to help? And so sleep latency, that's the amount of time it basically takes to fall asleep. So you can see with a placebo, let's say it's 11 minutes, and with melatonin dose in any kind of standard range, a couple of minutes faster going to sleep. Is that clinically relevant? I guess you and your patient would have to decide that. And then sleep efficiency, remember that's the amount of time actually asleep versus over the time in bed. Improves it again slightly, but again, you have to make the judgment as to whether that would be a clinically significant difference. Cannabinoids are, a burgeoning industry, and the question is how they can improve sleep. And the answer is still out. We don't know. There have been a number of intriguing studies that have shown benefits of CBD. So I would consider that. And also THC, in particular THCA. So there are different THCs, and THCA seems to be the one that helps the most with sleep. So investigations are ongoing. I think there's going to be some positive information that's going to come out about these, and so I would consider that as we move forward. There are a number of sleep tracking apps, and these are getting better and better. Most are based on actigraphy or movement. However, some of the newer smartwatches, such as the Apple Watch Series 6, actually has a very good pulse oximeter built into it, as well as other sleep tracking aids. And I think these are going to become more and more useful as we move forward. I want to touch briefly on obstructive sleep apnea. I think it's very important in anybody who reports trouble sleeping to review signs and symptoms of obstructive sleep apnea. One of the easiest things that you can do is an Epworth sleepiness scale. We use this on all of our patients, and basically it's a series of 8 questions, and it's asking them what is the potential that you would fall asleep in these various scenarios. And a 0 score means they would never fall asleep, and 3 is they'd almost certainly fall asleep in that scenario. Add those total scores up. If the score is greater than 10, that suggests excessive daytime sleepiness and consideration for obstructive sleep apnea. Can also, there are a number of apps out there for keeping track of snoring. The important statistic for snoring is about 60% of people that snore have obstructive sleep apnea. So just because you snore doesn't mean you have obstructive sleep apnea, but the odds are in favor that you probably do. And the only way to truly know the difference between primary snoring, which means snoring without any obstructive sleep apnea, versus obstructive sleep apnea, is a polysomnogram or a sleep study. The home studies have become very reliable, and if there aren't a lot of other issues such as medical comorbidities, oxygen dependence, things like that, a home study can be quite useful in terms of diagnosis. So if the patient has just snoring and not obstructive sleep apnea, and you've ruled that out with a home study, number one thing to try is positional therapy. And that's because when we're on our back, gravity is pulling the back of the tongue, the palate, other airway muscles, shall we say, posteriorly, and that's what's causing the blockage. So if we get them onto their side, very difficult to get most people prone, but if you can get them on their side, that can get gravity working more in our favor. There are a number of different options for that. The least expensive one is to get a t-shirt with a front pocket. So the tennis ball into that pocket, and then reverse the shirt so that they're wearing it, the pocket on their back, and that can help. There are also a number of wedges, and there are even alarms now that you can wear on your neck that when you move to your back can nudge the person into positional therapy. Weight loss is always important. And I tell patients that they don't necessarily need to get back to their high school weight in order for it to make a difference. A weight loss of even 10, 15, or 20 pounds can have a profound impact. There are some office-based procedures that can be applied for snoring, but usually we're going to start with positional therapy. For obstructive sleep apnea, we look at the number of events per hour, and again, less than 5 events per hour. That's both apneas, which are complete cessation of breathing for 10 seconds, as well as hypopneas, which are a partial obstruction in the airway that results in an oxygen desaturation and a sleep disturbance. Add those up. So less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. If they have no symptoms and they're in the mild category, limited therapy may be appropriate. If they have more than 15 events or they are symptomatic, it is very important for the patient to seek a referral. Treatment options, again, in the mild category, perhaps positional therapy might help, or weight loss. Always what we start with is positive airway pressure. Most often nowadays, that is AutoPAP, not CPAP. CPAP is continuous positive airway pressure. AutoPAP is variable pressure that the machine delivers to keep the airway open. Oral appliance therapy or surgery. And again, if it's moderate to severe, patient really should not go untreated. That is, if you look at survival curves, if you look at risk for stroke, heart attack, that really goes up when the patient is in the moderate to severe category. And that's why we say it really must be treated. Just to briefly hit on one, probably I would still call it newer or newest therapy for obstructive sleep apnea is a hypoglossal nerve stimulator. It also goes by the name of Inspire. Your patients might end up being exposed to this. They do have radio spots and TV spots as well as advertisement on social media. And it basically is comprised of a generator that is a small implant that's placed below the collarbone on the right-hand side. There's a sensing lead that goes down between the ribs, senses every time the patient is about to take a breath, sends that information back to the generator that then sends a weak electrical pulse up to an electrode that is literally wrapped around the nerve that goes to the tongue, causing the tongue and associated muscles to move forward and opening up the airway. So that's the hypoglossal nerve in a cadaveric dissection. And you can see kind of some nerves that are going off at more or less 12 o'clock there. And those are excluded from the cuff because they cause the tongue to pull back in the mouth. But those fibers that you can see at anywhere from, I guess, 1 o'clock to 3 o'clock or so, those all get included in the cuff. And those are called protrusor muscles that move the tongue forward. And that's just the cuff around the various nerves that move the tongue forward. Ends up with 3 small incisions. We're actually decreasing that to 2 incisions, so it's outpatient surgery. Patient goes home the same day. This just shows you the effects. If you look here to the left side with no stimulation, the far left is behind the tongue, and you can see that patient is basically breathing through a straw. That little area there is their airway. This is looking behind the palate, and you can see there's very little air movement, complete blockage there. On the other hand, with the therapy, you can see every time that there's the stimulation, now the breath stimulation, you can see how the airway cleans up very nicely. And even though we're stimulating the tongue, it has effects throughout the airway. And this just is an example of the palate. The palate moves forward as well. There's stimulation, opening, relaxation, opening again. So this can be a very effective technique for all right, go forward. There we go. This happened to be the first 20 patients that myself and my partner at that time, Dr. Alan Kaminsky, implanted. And you can see the pre-op range here, anywhere from the 20s to almost 70. And you can see every single patient does respond to the therapy. And for the most part, we can get that index at 10 or less. Patients are very satisfied with it. 19 out of 20 patients are happy with the device. and adherence, or how much time per night do they use it, is very high, 5.7. If you look at patients that use CPAP, a couple of large studies, these are patients that are actually happy with CPAP and they use it every night. Their average use was around 3.5 to 4.5 hours per night. So patient adherence for this device is even higher than those that are using CPAP. And so, in conclusion, insomnia is very common. You saw the numbers earlier. Older adults, sleep can be a challenge, and there are multiple causes for that. Advanced phase, we talked about that one in particular, treat with light. Sleep hygiene, like I said, there's 10 or 12 rules there, and work on one or two at a time. Cognitive behavioral therapy for insomnia, primary recommendation, certainly before we turn to any kind of pharmacologic intervention. And obstructive sleep apnea is treatable. We always try to get patients to do some form of positive airway pressure first. If that is not an option for them, then to consider an oral appliance. And where I come in is a little bit on the surgery front. And while I didn't talk about the full range of surgical options that are available to patients, for those of you that have been in the business a while, like me, surgery to me has gone from kind of a coin flip type of potential for benefit to almost everyone that we treat surgically, we can improve them, certainly with options such as the hypoglossal nerve stimulator. But don't think that for obstructive sleep apnea, the only thing we're doing is a uvular palatal pharyngoplasty, trimming of the palate. We have a lot more operations and options that are available to patients. So with that, there's a few references at the end here. Treatment of patients with positive airway pressure, the importance of exercise and sleep. Like I said, cognitive behavioral therapy for insomnia, as well as age, gender, and race discrimination and sleep, and a review performed of that. And that concludes the talk. Thank you.
Okay, thank you very much for the talk. We do have a couple of questions in the chat room that I'll read off to you. And if anyone wants to raise their Zoom hand and ask their questions, please do. So the first question is, this person's in-laws are by nature up all night and sleep during the day. They've had sleep evaluations and good sleep hygiene. Is that normal is it hereditary for people to be like that, to have their sleep hours shifted so much?
No, absolutely not. That is definitely learned behavior, and is clearly a sleep hygiene issue. And the important thing is that somebody that has their sleep phase that far out of whack, you're not going to fix them overnight, but it has to be a slow thing of gradually shifting their time asleep, and utilizing things such as melatonin, light therapy, and cognitive behavioral therapy are all very important. There is one can you still hear me?
We could hear you now. You're
Okay.
Cutting in and out.
Okay, yeah, I don't know, something happened to the computer there. Sorry. There is an hereditary condition called fatal insomnia. Sorry, my battery is going dead on the computer here. Hopefully we'll get through this. In which there is a huge hereditary component to this. It's actually a gene that's been isolated. And these patients get less and less sleep and until finally they actually succumb to the disease. So, but that's incredibly rare. And that's certainly not this case here.
Okay. My sleep tracker says that I spend only an hour in deep sleep. Is this a problem? And if so, what should they do about it?
Now, even though we consider deep sleep to be where a lot of the restoration happens, again, according to age, having an hour or two of deep sleep would be considered normal. So I wouldn't be overly concerned about that. No.
Okay. It seems like there's many causes for insomnia. Is there a standard procedure or process for diagnosis?
Good question. I guess the short answer is no. Kind of just going through that checklist, thinking about if there might be any medical comorbidities that are causing it, review the medications, are steps 1 and steps 2, and then step 3, almost immediately kind of move into the sleep hygiene questions, and just seeing if you can identify 1 or 2 things that you can ask the patient to change. And we kind of talked about those sleep hygiene issues. So that's and I would not turn to pharmaceuticals as a first or even second option. I would work on those other things first.
Okay. So another question, is it problematic if you have problems falling asleep to use Benadryl on a regular basis?
Benadryl, diphenhydramine is probably useful for on the order of a week or so, because we're depending on the side effect of the medication. But longer term, it really is not effective and can be counterproductive. So I would say if you're using it for more than a week at a time, you need to try to think about alternatives.
Okay. Does anyone else have any more questions at this time? I'm not seeing any more questions. So I'd like to thank you, Dr. Trask, for giving the presentation today. It's been very informative.
Wonderful. Well, thank you everybody for your attention, and have a good day and a restful night's sleep.
Okay, thank you.
Mm-hmm.
And I'd like to remind everyone that OLLI is on spring break next week, and there'll be no classes. Our next medical series lecture will be April 7th at 7 p.m. And the topic will be new developments in peripheral neuropathy, I mean. So thank you, everyone, and we will see you in 2 weeks.
Take care.